Hello, everyone. My name is Julia Glackham, and I am the Public Health Public Safety Fellow here at ADAPT. I'm excited to announce this morning's keynote speaker, Dr. Carlos Blanco, who will be discussing advances in prevention science. Dr. Blanco is the Director of the Division of Epidemiology, Services, and Prevention Research at the National Institute on Drug Abuse. He is a national known expert in the epidemiology and treatment of addictive disorders. Prior to joining NIDA, Dr. Blanco was professor of psychiatry at Columbia University Medical Center. He has also authored over 300 peer-reviewed publications. On behalf of the ADAPT team, I would like to thank him greatly for being here with us today. Dr. Blanco, over to you.
Okay, thanks very much. And it's actually, I have to thank you, Haita, and more importantly, the audience for participating in this event. And as the Director Labelle said, for all the work that you do in terms of prevention. So I'm very excited to share with you some of the knowledge that we have about prevention, but also engage in a dialogue with you at the end of the presentation. Excuse me. I thought I would start by creating some anxiety and some motivation. So some of you may know this opioid use disorder cascade of care in the US. So if you start on the left side of the slide, you can see that there are about 2.5 million individuals with opioid use disorder. And let me tell you that for this slide, blue is good and red is bad. So as you move to the right of the screen or of the slide, you can see that only about 60% of the individuals with opioid use disorder get diagnosed. Many fewer, about 20% engage in care. Even fewer get medication for opioid use disorder. Fewer get retained for 6 months. And only about 50,000 out of 2.5 million individuals get on continued abstinence. So 50,000 is about 2% of the individuals who have opioid use disorder. And I cannot really think of any other disorder, diabetes, hypertension, cancer, where people would get, only 2% of the people with the disorder would get treatment. So what that tells us is that because 98% of the people don't get treatment, obviously prevention is crucial. Treatment, even if we, let's say, even if we multiply treatment by tenfold, we will still only get 20% of people in treatment. And even, an increasing by tenfold is unthinkable. So prevention is crucial. You know that, and I'm preaching to the choir, but I wanted to give you some data and some motivation. Now, this cascade of care is restricted to opioid use disorder. But if you think about other substance use disorders, this is slightly different. So what we're looking here is at how long it takes for people to seek treatment in the US. And so on the left side, you have the probability. I have sort of truncated the axis so it doesn't go to 100% or to 1, which will be 100%. And then on the x-axis, you can see the number of years. So even for the more severe disorders, you can see that even after 30 years, less than 50% would seek treatment. And if you look at alcohol dependence, it's even fewer. If you look at drug abuse and alcohol abuse, even fewer. So that's another way of, again, thinking that the vast majority of individuals never seek treatment, and therefore prevention is crucial. One way to think about prevention is really basing it on epidemiology. So I'm going to give you a few epidemiological facts to give you the basis for thinking about prevention, but also, again, give you an armamentarium when you talk to other people about how to understand prevention and why prevention is crucial. So over the last 20 years, I think we have been very successful at promoting the idea that addiction is a disease of the brain. But as we all know, brains don't live in isolation. I have never seen a brain walking around by itself. So in reality, it's a more complex disorder. And so we can think about addiction as an interrelationship or an interface between biology, starting from genes, development, brain development, and environment. And depending on this interaction, people start using drugs. That's going to affect the brain, and that's going to lead at least some individuals to develop addiction. So that's a schematic view of how biology and environment interplay to develop addiction. But we can think again in a much more layered way. So we can think at the individual, but then not only the biology, we live in a community with family and peers. These families and peers are embedded in neighborhoods and communities. And those communities, of course, are regulated by laws and by culture. And then if we think in a different way, we can think of a developmental way about substance use disorders. So substance use disorders don't appear suddenly in one person, but rather they develop in this cascade of risk that I'm presenting here to you. And so this is just a schematic. Of course, you can think of other risk factors, other protective factors. But I'm going to go a little bit over this slide to explain the complexity of substance use disorder. So in the green tier, you can think of infancy and childhood. Then the red would be sort of early adolescence. Then blue would be late adolescence, adulthood. And then the last year would be the last year. And so you can see that even very early on, some people have a predisposition for substance use disorders. They have a family history. They may be victims of childhood sexual abuse. They may live in families that have disturbed environments. They could have losses. All these things can interact. So that already, even at one level, at one tier, you can see that the situation is very complex. Now, that of course is going to later on give us opportunities to develop prevention programs. But in terms of etiology, we can see that it's very, very complex. And also, in a way, it gives us a sense of how, even though the common pathway may be the same, we can see individuals with substance use disorders. There's many pathways, there are many different ways to get into this final situation. And so that, I think, at least for me as a clinician, makes sense that I see individuals that have very different histories, but have a very similar syndrome. So to go back to the cascade, so you can see this first tier. So let's say for the sake of the explanation, you have a family history of substance use disorder and you have childhood sexual abuse. That's going to increase the risk of somebody having impulsivity. Of course, the victim of childhood sexual abuse are going to have more likelihood of having lower self-esteem or early onset anxiety. So again, we see this cascade going down. If you have impulsivity, you may perform less in educational settings. You may be more prone to experiencing trauma. You have early onset anxiety or early onset of substance use, you're more likely to develop comorbidity. That's going to lead to probably a history of substance use disorders that may lead you to social deviance. So again, in terms of thinking about the etiology of substance use disorders, we can think of a very, very complex constellation of risk factors that interact both at the same temporal level, but more importantly, perhaps cascading towards the present. And then, of course, substance use disorders don't occur in isolation. They have often comorbidity. So in this diagram, what I want to show, the numbers are not really important. The important thing is to realize that in substance use disorders, including alcohol and drug dependence, are part of externalized disorders. These are correlated, or another way to say is that they increase the propensity for having other psychiatric disorders such as agoraphobia, panic disorder, social phobia, major depression, bipolar. And so again, in thinking in terms of treatment, but also in terms of prevention, just thinking about substance use disorders may not be enough because these are part of a broader constellation of psychopathology. And that also makes sense because, of course, we only have one brain. And so substance use disorders and other psychiatric disorders live in the same brain. So by nature, they're going to co-occur. So in thinking about prevention, we want to think more broadly, not only about substance use and substance use disorders, but how they get embedded in a broader constellation of disorders. We also want to think, as we think about substance use disorders as developmental disorders, about the age of onset of first substance use. And you can see that the probability of use of, the most common disorder, the most common substance is alcohol, followed by nicotine, but also the median age of use is quite early. So for nicotine, the median age would be 15. For alcohol, is about 18, maybe earlier now. Cannabis 17, probably again earlier these days, and cocaine 20. And another way to think about it is to look at how many people or what percentage of people have used different substances by 12th grade. These data are for the United States, but if you think, or if you look at international data, these are data from the World Mental Health Surveys, you can see that it's very, very similar across countries. So adolescence is really a key moment to think about the starting of substance use. We also want to think not only about use per se, but also transition. So not everybody who uses a substance is going to transition into developing a substance use disorder. And in this graph, also what I'm showing is on the vertical axis, the probability of developing a substance use disorder once a person has tried the substance. And then on the horizontal axis, the years, no? And so as you can see, even after many, many years, even after 40 years, there's still a probability that people will become dependent. So in terms of thinking about prevention, yes, the steeper part of the curve is in the first few years, maybe in the first 3 to 5 years, but there's always a risk if the person is using that they will develop dependence or they will develop a substance use disorder. So in terms of, again, of thinking of prevention, even though we may want to concentrate in the early stages of substance use, we want to think more broadly. And that's one of the gaps that we have in knowledge, how to develop preventive interventions for individuals who are not in adolescence or young adulthood. Also, in terms of thinking about prevention, again, this diagram is somewhat complex. I want you to look mostly at the right side of the screen. So in this study, what we did is we looked at different substance use disorders, and then we saw what the consequences of disorders are. And so as you can see, every disorder is going to increase the probability of divorce, problems with neighbors, low social support, increased violence, both as victim as perpetrator, higher probability of unemployment, financial crisis. And so even though these are initially consequences of substance use disorders, they can also eventually become a positive feedback loop and increase the probability of maintaining the disorder. So again, in terms of thinking about prevention, it's not only preventing the use, but also how do we cope with the consequences of substance use disorders so that in terms of rehabilitation and prevention of relapse, we take into account all these other circumstances. We also need to think about substance use disorders as chronic relapsing illness if we want to provide adequate prevention. So in terms of treatment, especially people who do not have training in substance use disorders, they tend to think in terms of episodic care or acute care. But those of us who are clinicians have experience in the treatment or prevention of substance use disorders. We know that it's a chronic relapsing illness. Some people, unfortunately, remit and never relapse, but many people, unfortunately, relapse. And so again, in terms of understanding the course of disorders, you can see this is a similar graph to the one I put about transition, but this one is about remission. And so you can see that many people who have the disorder remit. Eventually, most people actually remit over the years. But you can see also that, let's say for this, for cocaine, which is the one with the triangles, it may take up to 20, 30 years. So if you think of any other disorder, let's say hypertension or diabetes, eventually the person is going to remit from diabetes or is going to be free from hypertension, but it's going to take 20 or 30 years. The consequences that that's going to have on the body of the person, on the brain of the person, and on the life of the person overall is terrible. So again, we want to think about the course of disorders, and we also want to think not only that people remit, but as I was saying, that also people relapse. And as you can see, the probability of relapse is a sort of exponential curve. So initially, the riskiest moment for relapse would be shortly after remission. So again, if we want to think about secondary and tertiary prevention, we want to think what is the course of the disorder so that we can put most of the resources when the person is most likely to relapse. Another issue I wanted to bring up is the issue of switching addiction. So when I was in training, many of the clinicians would say, well, why treat individuals with substance use disorders? If they remit from one disorder, they're going to develop another addiction. But the data actually showed the opposite. If we are able to improve or get somebody to remit from one substance use disorder, that's going to decrease the probability of developing another disorder 3 years later. These are data from the NICHAR, which was a very, very large epidemiological study conducted about 10 years ago with 40,000 people. And so again, what the NICHAR showed is that if we are able to get one person to achieve remission, that in a way is already a preventive intervention because it's going to decrease the probability of that person developing other substance use disorders, and eventually even other psychiatric disorders. So in terms of doing prevention of substance use disorders, the benefits spill over to preventing other disorders. Now, I've given you a sort of brief overview of what of the epidemiology that can serve as a basis for prevention. Now I want to show you a little bit what we know about prevention. And we can think of prevention in a way as experimental epidemiology. So we have learned the basis of epidemiology, and then we can develop, or we should develop, preventive interventions based on that epidemiological knowledge. And so I bring back again this slide that I showed you a little bit earlier in terms of what could be potential targets for interventions. And so we could intervene at the individual level. We could potentially develop, we don't have them, but we could potentially develop medications that serve as preventive interventions. We could act at the level of biology. We could act at the level of peers, and we could also act at the level of communities or laws and culture. Now, as you will know, most of what has been done so far is really prevention at in childhood and adolescence. And so I'm showing you here just as an example some data from Prosper. Prosper, as you know, is not actually an intervention but a delivery platform. But you can see that using Prosper is one way to be actually quite effective. But again, this is focused on middle school, essentially on school age individuals. And this is another way to looking at the data, showing that individuals who experienced or who received the intervention did better than the controls. This is another intervention. The Seattle Social Development Program. And again, you can see that if you receive the intervention, you do better than the controls here, having the lowest bar. Who receive the intervention are less likely to have early sex or to use alcohol or to use cigarettes. And here again, another example of raising healthy children intervention, and yet one more from the communities that care. So again, most of what we know in terms of prevention right now is that there are several school-based or school age-based interventions that are effective, but we know much less about interventions for other ages. One of the things that has been tried is the prescribing guidelines for opioid use. But even though these are sort of consensus-based guidelines, there is relatively little empirical evidence about the efficacy and effectiveness of these guidelines. So we are not saying that these interventions are not effective, but the evidence needs to essentially be developed. So the first part of the talk, what I did is I present a little bit the epidemiological basis for prevention. I've shown you a little bit about what we know about prevention, which again is sort of a school-based interventions, but much less about other ages. And so I wanted to bring up a little bit what are some of the things that could be done to improve prevention, or essentially what is that we can do to change the drug abuse trajectory. So there are a number of things that we can do. One thing that we should do, or the first thing we should do, is pay attention to the epidemiological data. So as an example, even though we are right now very focused on overdoses, obviously that's a very, very important issue, we should not forget about tobacco. Tobacco is the main risk factor of premature preventable death. So we should pay attention to tobacco and also to e-cigarettes. E-cigarettes is something that is, essentially new for us compared to combustible tobacco. And the jury is still out about the pros and cons of e-cigarettes. There are potential benefits in terms of perhaps even helping quit smoking, but there's also concerns that it may be a gateway drug to smoking combustible tobacco and eventually other drugs. So also the use of e-cigarettes can normalize the use of tobacco. And also we really don't know much about the effects of nicotine on the developing brain and how changes in e-cigarettes may impact these exposures. Also, as you know, e-cigarettes are being used to use other substances, including cannabis. So again, one of the first things we can or we should do in terms of developing interventions is pay attention to the epidemiology, to what are the drugs that are most commonly used, and also what are the trends in the use of drugs. We should also think how interventions work. So there are certain background factors that we have to take into account and we can essentially not modify, such as age or race. Genotype we cannot modify for the moment. Maybe as we develop more knowledge into genetics, we might be able to modify the genotype, but at this point we have to take it as given. But on the other hand, there are many modifiable risk factors and protective factors that we can intervene on. And so we can, if somebody has social skills deficits, we can provide interventions to teach them social skills. We can intervene to provide better education, better access to education, improve the quality of education. We can intervene to modify deviant behaviors. We can improve the quality of neighborhoods. So there are many ways in which we can intervene. And so on the right side, the interventions that could be developed. So understanding the reason I'm presenting this slide is because, again, understanding how interventions work can help us first develop the interventions, but also select interventions in a way personalized prevention. We also want to think about how to innovate in terms of prevention. And so again, I hope that in the question and answer section, we can engage in this dialogue. The way innovation is often thought of is in terms of essentially smart people, innovators, researchers who develop an intervention and then hope that everybody else is going to adapt or adopt this intervention. But one problem with this approach is that often people who develop the interventions, and you as practitioners are well aware of that, don't take into account the conditions on the ground. And so sometimes researchers develop interventions that may not be particularly feasible or useful for your communities. So I think a better model to think about prevention is develop what is called in the treatment settings, a learning healthcare system. And so what we should do is have people who are on the ground, on the field, in the trenches, raise what are the public health needs, identify what the needs are, what is that we need to solve, and to generate meaningful research questions, and then partner with researchers because the researchers know how to develop interventions. So in a way, the people who are dealing with the problem, as I said, on the ground can generate the research questions, and then the researchers can help generate answers. But what we don't know is researchers generating answers for questions that may not be that meaningful for you who have to administer the interventions and have to actually prevent substance use. And so one way to think about, again, how to develop better preventive interventions is to engage in this dialogue and iteration where some questions are generated. Researchers would design an intervention responding to the needs, which, in some cases can be as now, maybe the opioid crisis, but could be tobacco, could be methamphetamine, whatever the problem is. And again, in some settings it will be a school, but in other settings, let's say in the context of opioid use disorder, most individuals don't start with opioid use disorder in school. So maybe we need to see how do we develop interventions for young adults, how do we develop interventions for the elderly. So whoever is engaged in prevention will generate these questions. The researchers will design the intervention, then it gets implemented. Hopefully it will have some efficacy, but it's not going to be perfect, like most things we do in life. The first time we try them is not going to work. And then we evaluate the intervention, not only in terms of efficacy, but more in detail, what has worked and what has not. And then we adjust and we iterate, and that's how I think we should develop prevention. But again, I would be interested in getting feedback from you about your experience, both in administering prevention, but also in working with researchers. As I mentioned earlier, so we can intervene at different levels. And so I'm putting this slide back to remind you about the complexity of the etiology of substance use disorders. And so the complexity makes it difficult to intervene. At the same time, we can see that there are many targets on which we could intervene. So depending on the population, depending on your skills, depending on the motivation of the community, it may be better for certain communities or for certain settings to intervene at different levels, and also obviously depending on the age of the individual. So we can intervene at the individual level at all these many different levels. We can also, one of the things in which we want to advance prevention, and we actually had a meeting last week about this, is to get a better understanding of the biology of the individuals. So right now we act mostly based on epidemiological data, phenomenological data, but it would be great if we could get a better understanding of the brain and then use that knowledge of the brain to develop interventions. That's not going to happen immediately, it's not going to happen overnight, but if we don't invest in the future, then we're not going to be able to develop better interventions. So one of the ways in which we at NIDE are trying to understand or develop better interventions is by understanding the brain better. And so the best example probably is the adolescent brain cognitive development study, which some of you may be familiar with. And this is a longitudinal study of over 11, actually, it says $10,000, but it's actually over $11,000 kids that were recruited when they were ages 9 to 10. And they're going to be followed for about 10 years. And basically the goal of the ABCD, as we call it, is, I mean, it's going to generate a lot of information, but in a simplified way, if you will, we want to know what are the effects of biology and environment on the brain, and then how the brain adapts to this environment. And so we're going to be measuring, try to get a sense of the normative development of the brain. We are going to try to see what is the role of the interaction between genes and environment, the role of physical activity, the role of sleep, the role of screen time, but also what is the role of, if you will, sort of macro factors, like racism and discrimination, changes in laws and policies. So it's a very exciting study in the sense that it's really, at least in my opinion, the best integration we have so far of biology, environment, and longitudinally, so that way we're going to be able to generate better inferences, and hopefully from that knowledge we will be able to develop better interventions. The ABCD has been very successful in recruiting the sample and also maintaining the sample. And one of the things that may be of interest to some of you, I know that some of you are practitioners, but some of you are also researchers. So it is possible to download the data, to get the data from the website and generate analysis. So one of the things that I encourage you to do, as I was saying before, is to identify what would be meaningful public health questions, and then go to a data set and try to use the data to answer those questions, so that the knowledge that we generate from the ABCD is not just sort of intellectually rewarding or knowledge that is going to be in paper, but it's going to be really knowledge that is going to transform society, it's going to transform prevention, and it's going to advance public health. So one of the things, as I said, that we can do to advance prevention is to understand all this constellation of risk factors. The second level at which we can intervene is by understanding the brain better. A third way to think about prevention is by realizing that, as this diagram that I put before with many levels, individuals don't interact or don't live alone, but rather interact with people. And we have good evidence that networks have an influence on how substance use is spread, but also how the effect of interventions spills over to other individuals. So we can think of interventions that could have spillover effects and maybe identifying certain nodes in the networks that could be particularly influential. I mean, we all know that there are influencers in every community. So by being able to maybe target the preventive interventions on the influencers, we can multiply the effect of the of the intervention. Then I wanted to briefly call attention to one of the initiatives that we are funding at NIH. As you know, we have the HEAL initiative, which is a sort of multifaceted intervention. But one of the things that we are doing is putting emphasis on prevention. And so we are focusing on 4 different components. One is risk identification, then intervention development. We are also examining the role of social determinants and inequities, and also, of course, dissemination, implementation, and scale up. One of the problems that prevention has had, or at least evidence-based prevention, is that interventions get developed, but then they don't get adopted and disseminated. And so it would be like developing a medication that nobody takes, or if you want to, a more trivial example would be like somebody who manufactures toys, but then kids don't want to play with the toys. well, that's not so useful. So we develop interventions that nobody wants to use. It's not very effective. So in HEAL, what we are trying to do is not only develop interventions, but also pay attention to dissemination and implementation. And we have focused on a number of areas. So as I have mentioned several times in the talk, most of the preventive work so far has focused on school-aged individuals. Here, we're also trying to extend to late adolescents and young adults. So we are studying the effect of community and social services. We are also trying to study some interventions in terms of healthcare, and also, of course, juvenile justice, because individuals who are involved in the justice system are at a higher risk of developing substance use disorder. So it's very important to develop interventions for those individuals. And then, even though I put this slide before to show the efficacy of the communities that care, I'm putting it now here to show that one of the ways in which we could also affect effective interventions would be to modify laws and regulations. And so, even though often we think about prevention as acting at the individual level and giving the individual specific skills, resilience, refusal skills, or even preventing individual events, it's going to be difficult to provide at the individual level enough prevention for everybody. So one way to multiply the effect of prevention would be to think of what laws, what regulations, what community interventions can be developed and can be implemented that could affect a broader swath of the population. One more thing I wanted to bring up is that even though we can have a plan and we can develop interventions, every plan is going to be derailed. That's the way life is. We make plans, but then plans don't happen. And so I'm just bringing up COVID just as an example of how we need to adapt to the new situations. And so in terms of prevention, we have to think not only how we would do prevention in an ideal world, but also how to adapt to things that are going to be thrown at us. And then just to finish, the first slide of the talk, because I think it's the most important slide of the whole presentation. Treatment is not enough. We're putting a lot of emphasis, the country is putting a lot of emphasis, not only the country, the whole world puts a lot of emphasis in treatment. I'm a clinician, so I'm of course in favor of treatment. I think treatment is crucial. People should have access to treatment, but treatment is not enough. You cannot take care, or we will not be able to solve the opioid crisis or any substance use crisis or any substance use problem just with treatment. We need prevention. So thanks for your attention, and I think we have a few minutes for questions and answers. So I'm looking forward to the dialogue. And I've given you more ideas, but I'm looking forward to your ideas and to the dialogue. So thanks very much.
Thank you, Dr. Blanco. We are going through some of the questions that have come in from the audience. Would you mind taking a few of those?
No. I mean, that's the most important part of the talk. I mean, the dialogue. And I'm sorry that we cannot do it in person, but tell me your questions, and then again we can have a dialogue.
All right, wonderful. The first question coming in is, when talking about youth engaging in marijuana use, what is the impact of referring to it as cannabis versus marijuana?
I don't think that, that's a very interesting question, no? And I don't think it has been systematically studied. My view is that the important thing is to use a term that would not be stigmatizing in that community. So I didn't bring up the issue of stigma, which of course is crucial in my talk because there's only so much we can talk about. But I think that one of the things that deters people from seeking help, either at the treatment level or at the preventive level, is a stigma. In certain communities, cannabis is seen as a more neutral term. So in that sense, I would use that. I generally use the term cannabis when I write for scientific audiences, but other people prefer to use marijuana. And I think, again, the important thing is not to stigmatize, but rather to be open and accepting about substance use, and not see it as a vice or as something immoral, but rather as a medical disorder the same way. I mean, I think maybe an analogy would be if we are talking about diabetes, is it better to talk about glucose or is it better to talk about sugar in the blood? Well, I mean, maybe one term is technically more used in the medical literature, but I think the important thing is, again, for people to feel accepted and feel that they can access and approach health professionals and get help.
Thank you for that. The next question is, have you heard about reward deficiency syndrome, and could it help in identifying risk?
Yeah, I mean, reward deficiency syndrome, I mean, it's a very well-known concept. I don't know when it was first developed, but I mean, probably about 20 years ago. And yes, I think identifying reward deficit syndrome is one of the risk factors. Again, in the slide I put about like different risk factors, I only put a few of them because otherwise the slide would be unmanageable. I think one of the, yes, anytime that you can identify a risk factor, it provides an avenue for prevention or treatment. I think maybe the difficulty with that particular concept in terms of prevention is that we don't have very good tools to assess that. And so in that sense, it would be, if we were able to develop a good scale or an easy to administer instrument, then we could potentially use it as a stratifying variable. I think right now we don't have that. So, you know, it's an idea for the future. I think right now it would be difficult to implement.
Okay, thank you. The next question is in regards to decriminalization of drug possession. And they're asking, do you see statewide decriminalization of drug possession playing a role in prevention in some way? This participant is from Oregon, and they aim to replace criminal justice cycles with treatment pathways over time. That's what they're pursuing there. What are your thoughts on that?
Yeah, so I'm a scientist. I'm a clinician, so I don't make laws. So I don't give advice on whether things should be decriminalized or not. But from the scientific point of view, what we have seen and what everybody has seen is that decriminalizing substance use tends to improve access to treatment and prevention. I mean, of course, if somebody is going to go to jail for seeking treatment, it's less likely that they're going to seek treatment again. If you put the analogy, I mean, we live in a society in which we have gotten used to substance use as a criminal behavior, but not all societies are that way and not all disorders are treated that way. So if you think about a society in which having diabetes would be a crime or eating too much chocolate, I happen to like chocolate, no? So if you know, if I live in a society where eating chocolate would be a criminal behavior, and then suddenly I couldn't get treatment for diabetes because I could go to jail, then of course many fewer people would get treatment for diabetes. So again, I'm not going to give a legal opinion because that's outside my purview and my domain. But from the scientific point of view, the data seem to show that decriminalizing substance use tends to improve access to treatment outcomes, prevention, and overall advanced public health.
Thank you. You mentioned communities that care and strengthening families, those strategies. Do you have any additional research or thoughts on Botvin's life skills? And we see Botvin's implemented across the US in multiple HIDA communities. Do you have any additional thoughts or research to support Botvin's life skills curriculum?
I don't have any resources with me right now, but you know, you can email me at NIDA, and we will be happy, either me or one of the people who work on my division, to give you additional information on the scientific data supporting that intervention and also where it has been implemented, and potentially some help on how to implement it in your community if you're interested.
Okay, great. And you can also email us at ADAPT. We have on our ADAPT website a list of all the registries that will give you the current evidence that is available. And Dr. Blanco, we will reach out to you as well. And if this individual would like to email ADAPT at wb.hida.org, then we'll be able to get you the response to that if there is.
Yeah, and my email, I mean, I didn't put it in my slides, but my email, if you go to the NIDA page, you know, You can find, and you Google my name, it's easy to find my email. And again, you can email me, and one of us, either me or somebody in our group, will get back to you.
Wonderful. Thank you, Dr. Blanco. Okay, there is a new wave of Delta 8 THC. Please, what is the impact, especially on the youth, related to this particular substance? And how different is Delta 8 from Delta 9 THC?
Well, obviously, I mean, one of the things that we have seen over the years is that that the potency of cannabis has increased, no? And so one of the effect of substance use is going to be a combination of the frequency of use, but also the intensity or the concentration of the drug. I mean, that's true for cannabis, but it's also true of opiates. No, I mean, that's why when we see more fentanyl in opiates, the rate of overdoses and the number of overdoses has increased. So one of the things that we have observed over the years is that as the potency of cannabis has increased, the number of individuals who, conditional on the number of users, the number of individuals and the severity of cannabis use disorder is greater. No, so we're concerned that as the potency of cannabis increases, we're going to see more and more. I mean, increased prevalence of cannabis use disorder. Now, one of the things that complicates assessing that is that, as we all know, cannabis is becoming legalized in more and more states. So, you can use, let's say, the NISDA, the National Survey on Drug Use and Health, to look at the difference between the effect of policy and the effect of increased potency, but it's not easy. Now, in terms of laboratory studies, one of the things that NIDA has recently done is that quantifying the use of cannabis is often complicated because as this question is sort of hinting, the amount of cannabis is not the same in every dose. So one of the things that NIDA has recently done is develop a standard dose of cannabis, so that when people do studies, either epidemiological studies or lab-based studies, we can more easily compare the effect of different amounts of cannabis.
Thank you. And I think we have time for one more question, and this is related to the ABC study compared to ACEs. So can you expand on ACEs and prevention? In particular, is the ABCD study going to be utilized side by side and as a partner, or instead of or in place of ACEs as we continue to collect data and work towards prevention goals?
So the ABCD is not going to, I mean, it's an independent study, so it's not going to necessarily work side by side with other studies. However, the way, as I imagine the person who has asked the question knows, what everybody does when we do research is we put the research in the context. We do two things. We put the research in the context of what has been done before, but also at the end of the research, we also project what can be done in the future. Now, again, as I said, the ABCD study, because of the size, but also because of the longitudinal design and the number of variables, the ABCD study has 50,000 variables, just to give you an idea of the magnitude of the knowledge that can be acquired. So investigators who work with the ABCD study will be able to put the data in the context of ACEs. And the way I think about science is not of a competition, but rather a collaboration. No? So ABCD has certainly benefited from previous studies, including ACEs, and will continue to benefit, again, by engaging in this dialogue. Also, you want replication. So whatever findings there in certain studies of the ABCD, they will be, I'm sure that the investigators will compare it with ACEs or with other studies and identify how the findings converge, or if there are differences, try to explain differences. I don't know if that answers your question, but I hope it does.
You did. And actually one more came in that I think reflects the spirit of today's summit, and it really is targeting the youth population. And they're wondering what your thoughts are from a NIDA lens, right? What are your thoughts on how can we engage youth more effectively in substance use prevention strategies, especially during the COVID-19 pandemic?
Well, I mean, obviously it's very difficult, no? Because if it were easy, they wouldn't be asking the question. But I think the way substance use prevention has moved in the 20 or 30 years I've been working on this topic is more towards a medical model and less towards a criminalization model. No? I think if you try to scare people about how bad things are, I think most youth are not going to believe it. No, I didn't believe it when I was a kid, and kids these days are not going to believe it. So demonizing drugs, I don't think is very effective. What you want to do is educate people and give them choice and show that in life you can make choices, and some choices are going to lead you to a happier and healthier life, and other choices are more likely to lead you to a less healthy life. So again, if you think about cholesterol or diabetes or hypertension, these are disorders that are not thought of, or obesity, that are not thought of as moral flaws or criminal behaviors. And so by putting it in the context of the benefit of the individual as opposed to the individual doing something that is right or wrong, I think it's easier to engage youth. Again, I realize it's difficult, no, because young people by nature think that they know everything and they are not going to suffer any adverse consequences. But to the extent that we can engage in a dialogue and show them that we're trying to help and not trying to condemn or put them in a bad situation, I think that's going to be, that's in general, in my experience, and that's what the evidence shows. It's a better way of engaging people and again, improving their outcomes.
Dr. Blanco, I want to sincerely thank you for joining us today and for offering your thoughts on NIDA's approach to prevention so that we can get a better understanding of where you guys are at, but also where you're headed and how you're thinking through things. We really value your contributions today and your comments. I apologize we weren't able to get to a lot of the questions. Dr. Blanco, we will be sending you a summary of the questions that did come in so that you'll see what people are asking and what they're interested in. Thank you.
Thank you very much.
At this time, we're going to be concluding the morning keynote session, and we are scheduled for a break until looks like 10:30. So at 10:30, if you could log on to the next session, which is by the Centers for Disease Control and Prevention. We have 2 speakers in that session, and you will find the link to that session in the lobby. I do want to mention we've had a lot of comments coming in that sometimes when they click on the link, there's another box that pops up that says join in session, and clicking on that one works for a lot of people too. So try what you can with what's available, and hopefully we will see you on the other side. So 10:30, we'll see you at the link for CDC. Thank you.